You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by Continuing Education Company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
Okay, here's Sheila. So this is an actual case from my clinic. History of obesity, type 2 diabetes, mixed hyperlipidemia, steatotic liver disease. Theme, she's concerned about her weight. She gained weight during COVID. She has been trying to follow a low-carb diet, but has not been successful at losing weight. She has a history of back problems, which limits her ability to exercise. She was diagnosed with diabetes 12 years ago and has been on metformin. She was treated with sitagliptin and empagliflozin, but had adverse reactions to both. Here's her past medical history as described. Medicines include metformin, 1,000 daily, losartan, hydrochlorothiazide, atorvastatin, fenofibrate, levothyroxine, venlafaxine. That's a lot of medicines for a young woman, right? Here's her weight. BMI is 30, blood pressure not ideally controlled. Generalized obesity, otherwise normal exam. And here are her current labs. Her A1C is not well controlled at all, 9.2. GFR is down a little. AST, LT up a little. Urine albumin-creatinine ratio elevated. And her triglycerides are 462, so you can't calculate the LDL. And we confirmed that this was fasting. We had platelet count. We know why, right? To calculate that FIB4. And then TSH is normal because she's on levothyroxine. The rest of her BNP is normal. All right. So here's my assessment of this lady. She has uncontrolled type 2 diabetes on metformin monotherapy without ability to tolerate a couple of agents. She has mixed hyperlipidemia on the statin, good, but triglycerides are still elevated despite being on fenofibrate. She has class 1 obesity with multiple obesity-related complications. She has MASLD with a FIB4 score of 1.53, which is mild fibrosis, so not MASH probably. Hypertension, not well controlled. Albuminuria, CKD 3A. Whew, that's a lot of problems. So which of the following is best next step in this patient's care? I'll just let you guys read it, and we'll let you guys answer. Okay, 97% of you said D. Let's focus on better glycemic control, good, and weight loss by adding either a GLP-1 or GLP-1 GIP. All right, so I agree 100%. And I mean, nothing, absolutely, no. You know, we certainly want to focus on lifestyle changes, but she's failed. We could add basal insulin, certainly not unreasonable, but I think that's not really taking care of the problem. And then I'm not, triglycerides are elevated, but weight loss is going to help bring those down and better glycemic control.
Well, with her weight, you wouldn't want to go with basal insulin.
Well, I mean, you could. It is an option. It's on our list of potential options. But the problem with basal insulin, what's metformin do? It reduces hepatic glucose production. What does basal insulin do? It lowers hepatic glucose production. So using two drugs that have a similar mechanism, you're not actually, you're not controlling her postprandial hyperglycemia, which she likely has. That's the advantage, in my opinion, of GLP-1. Having said that, you could add insulin, but it's not ideal, and it might lead to weight gain. So,
the triglycerides 400 is. How much do you think the weight loss with semaglutide would impact that?
I think significantly, and better glycemic control.
Yeah.
So the two together, I think her triglycerides, I would guess, would be in the 200s.
Yeah,
she'll still need maybe some.
And the Vascepa wouldn't. They're not. They could be used together. So I think
could be. We could, but it wouldn't be my priority.
Actually, 100% of the people were thinking of something that was reasonable, right. Although 97%,
right,
was good. And the other thing I would ask is, in the triglycerides being 400, if you calculated her non-HDL, it was quite elevated.
Sure.
Can you calculate a non-HDL in the setting of hypertriglyceridemia?
I don't know what it means when they have severe hypertriglyceridemia, because when your triglycerides are over 400, a lot of those triglycerides are packaged in chylomicrons at that point. And so we don't really care about the chylomicrons from a cardiovascular disease risk per se. So again, for me, that's not the priority. She's not at 700, 800, or 1,000 where she's going to get pancreatitis tomorrow. Priority is get diabetes.
So there'd be an option for ApoB there.
Yeah.
Oh, absolutely.
So
you can get ApoB.
And the triglycerides, a lot of it is in large VLDL. So it's not a lot of extra VLDL particles. Any ApoB elevation wouldn't be ascribed to VLDL. It'd be more to the LDL. So I think that would be a good test in that setting.
Absolutely. But again, I think you prioritize when you have too many problems, you can't take care of them all. That's the same time. All right. After reviewing the options, we decided to start Sheila on semaglutide in light of her high ASCVD risk and kidney disease, in addition to continuing metformin and providing more lifestyle counseling. 3 months later, she was taking semaglutide. She was now up to 1 milligram on tolerating well. She had lost 30 pounds, and her A1C came down to 5.6. This is real. This is not made up. She went from 9.2 to 5.6. And that's not a lot of weight loss. That tells you how much even modest weight loss impacts glycemia. Her blood pressure was also improved, but not quite at goal. Her triglycerides came down to 239, and her LDL was now calculated down to 78. All right, what would you do next? A, continue current management, consider increasing semaglutide to 2 with a goal of more weight loss, consider stopping metformin, start her on icosapent ethyl. E, B, and C. All right, so 60% say B and C. You know you're good test takers, right? Whenever you see an answer that's this and this, just circle that one because that's most likely what the guy writing the answer. So I continue current management certainly is reasonable, right? She's doing really well. You could just stay the course, right? I would say more weight loss would be better. And so maybe she'll get more weight loss with a higher dose of semaglutide. So I would recommend considering. Polypharmacy is an issue, right? And she's on a lot of medications. Her A1C is 5.2. Does she need metformin anymore? And I would argue she doesn't. Remember, the guidelines say we don't need to start with metformin up front. I don't believe that metformin has magical properties that impact, certainly not cardiovascular disease. There's not a single study that shows that metformin reduces cardiovascular disease. Does it reduce cancer? Does it affect Alzheimer's? Other things. Start her on icosapent. That's certainly reasonable. Her triglycerides are still elevated, so they're quote, persistently elevated in a high-risk individual. But I would like to see if she lost more weight, would her triglycerides continue to improve? So my answer was B and C. Again, that's what I did, but
I agree. Should agree. Yeah.
My answer would be put her on losartan HCTZ instead of 2 separate pills.
Oh, she was on a combo pill. It's just I listed them.
Oh, no, she wasn't.
She wasn't?
No, because you would have had a slash.
No.
When you have a fixed dose combination, you put a slash.
No, she was on fixed dose.
There's no slash.
And you will too on your chart.
No slash. No slash.
No slash, baby.
All right, good. Again, I think this whole idea of stopping metformin is, I think what I thought Jan was not going to like, but I think I've prevented this case before. And so, what about our CVD risk? What do we do next? So I'll let you guys read them and answer them. All right, so again, test takers say when you see an all of the above, consider that one, right? So 38% of you said all of the above are reasonable. So let's go through it. So add low dose aspirin. Again, it would be considered in the ADA guidelines because she's high risk. You could retry her on SGLT2. She said she didn't tolerate before, but what does that mean? Get a better history, because I think, again, that could be a beneficial medicine from a cardiovascular risk perspective. Could add a calcium channel blocker. Reasonable if her blood pressure is still uncontrolled, adding a third agent. Again, icosapent ethyl would be considered if she has persistently elevated. And I would potentially, you could do it in addition, or you could scrap the fibrate. There's really not a lot of great data for fibrate.
Yeah, get rid of the fibrate.
Push the statin dose to high intensity. Her LDL was 74. I think we would all agree that maybe less than 70 would be better for her. Yeah. And so I would bump the statin dose. So I really think all of these are reasonable things to consider in her care. Not saying that we should. We're not but I think they're all things to consider. And I think that gets to the taking care of the whole patient, right? So considering all the issues, it's not just about her diabetes or her lipids or her blood pressure or antiplatelet. There's all of the above.
Yeah, one thing you didn't get to, and that was on the original liver function test.
Yeah.
Those LFTs are just strikingly abnormal.
Right.
And the FIB4 was above 1.3, and she needs transient elastography.
I would say my hepatologist would say no, because she was mild fibrosis. You don't necessarily need it. Work on weight loss. Okay. And she's on semaglutide, which has shown to improve. So I would would see what her liver enzymes are the next time.
Oh, okay.
Before we do it. But you're good point.
Yeah.
And we underuse that test for sure.
And your comment about minimizing medications, I would add the Vasipa, because that's proven cardiovascular benefit in these patients. So the LDL cholesterol, I might only she's already on a statin, so it's not wrong to intensify the statin. But there, I'd rely on. I'd look at the ApoB too, because I'd treat that to target in this patient.
You're both diabetologists as well as obesity experts and the whole cardio-kidney thing. Are you used to writing 10 milligrams of atorvastatin? Or does that take a lot of you put her on 10 milligrams of atorvastatin?
That was when she came to me.
Yeah.
On that. I didn't put her on it. She was on it when she came to me.
Okay, but you didn't change it.
Not initially, because there was too many other things that I was concerned about. She was at least on a moderate intensity statin.
Got it.
So I'm happy that's at a minimum, right?
Yeah.
Yeah.
Okay.
But agree, I wouldn't have started her on 10, but...
Good point, though. Just
go for it.
I just...
I mean, the CARD study, that was 10 milligrams of...
a lower LDL cholesterol is not going to be harmful, and it can only help. So, go for it. If the drug is well tolerated. Of course, statins, there's a few people that don't tolerate statins. But
Thanks for watching. If you found this discussion valuable, be sure to subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.